Hello, everyone. I am delighted to welcome you to this insightful podcast with a distinguished uro-oncologist, Dr. Gopal Sharma. Today, we embark on a journey to explore the complexities surrounding bladder cancer, a disease that affects millions of lives worldwide. It ranks as the 10th most commonly diagnosed cancer, characterized by the highest recurrence rate among all malignancies. The incidence of bladder cancer is twice as high in developing countries compared to developed countries. Let's delve into this topic through a series of engaging questions exploring various aspects of bladder cancer, diagnosis, and treatment. Our esteemed guest will share his expertise on everything from the most frequently observed types of bladder cancer to the cutting edge therapies that offer hope to patients facing this challenging adversary. So, welcome, Dr. Gopal. It's a pleasure to have you here with us today.
Thank you very much. Pleasure is mine, and thank you very much for kind introduction.
Yeah, thank you, Doctor. So, without any further ado, let's begin our discussion. So, Dr. Gopal, can you please enlighten us on which type of bladder cancer is most frequently observed among patients?
So, first of all, bladder cancer is a cancer which arises from the inner lining of the bladder, and the most common cancer for bladder cancer is transitional cell cancer. And there are other various rare type of cancer, I would say, which are less than 5 to 10%, which are at least in India. Second most frequent type is squamous cell carcinoma, and third most common type is adenocarcinoma. And there are other very rare types of cancers which are called neuroendocrine tumors and mixed sort of tumors or poorly differentiated tumors.
Yeah, so now, Dr. Gopal, there are some important risk factors like smoking, certain infections, and occupational exposure to particular chemicals. But
Yes.
are there any modifiable risk factors?
As you correctly pointed out, the most important and commonest factor found with bladder cancer, which is found in more than 50% of the patients, is smoking. And smoking is one of the most important modifiable factor. The other factors are industrial exposure to aromatic amines or hydrocarbons, which are commonly seen in dye industry, paint industry, rubber industry, petroleum industry. These were classically believed to be an important risk factors. And there are other risk factors for other and mind you, these two risk factors are important risk factors for transitional cell cancers. There are some other risk factors for squamous cell carcinoma of bladder, which are not common in our country. First is bladder infestation with schistosomiasis, which is more common in Mediterranean countries such as Egypt. And there are other risk factors such as chronic stone or chronic urinary tract infections, which leads to this type of bladder cancer. So yes, one of the most important modifiable risk factor is smoking. But smoking is not only related to the increased risk, but it is also related to the recurrence of the disease. If once you have this disease, if you don't stop smoking, you will have increased chances of recurrences. And the smoking, the risk of disease reduces with the increasing duration of smoking cessation.
Yeah, Doctor, let's now shift our focus to the approach of its management. So, what is your approach to assessing a patient who is suspected of having bladder cancer or presents with symptoms indicative of the condition?
Yeah, so the most common symptom a patient could have is a blood in urine or hematuria, and some patients may have unrelated symptoms such as lower urinary tract symptoms, mainly irritative or voiding symptoms. And evaluation of a patient with hematuria or blood in urine should be complete and should involve complete evaluation of lower tract as well as upper tract. So for a patient with hematuria, what we usually do is we do a CECT urogram to evaluate upper tracts, that is kidney and ureters. And we also do urine for malignant cytology to look for cells which have been shed into the urine. And the last but most important thing is to do cystoscopy. And it is a dictum that even if any of these investigation finds any abnormality, the complete set of tests needs to be done. For example, if there is a problem noted in the kidneys on CT urogram, it should be followed by flexible cystoscopy, or cystoscopy should be done in that case. So complete spectrum of tests should be done, and the management protocol depends upon what is the finding in that investigation. Now, the most common finding would be bladder mass would be noted on cystoscopy in a patient, since we are talking about bladder cancer. So what we usually plan and work up and counsel the patient for transurethral resection of bladder tumor. It is basically a surgery in which is done transurethral, and in which we resect the tumor, and completely, if possible, resect the tumor and take the deep biopsies, and we wait for the histopathology specimen to come. It is not only a diagnostic, and it is many times a therapeutic procedure. And depending upon the histopathology report, the further tests are done.
Yeah, thank you, doctor, for providing your insights. Now, what is the first surgical procedure you do to stage and grade bladder cancer? What information you are looking for from that?
So yes, this is a very pertinent question in cases of bladder cancer. So the first surgical procedure we do is, as I have previously mentioned, we do is a TURBT, which is called transurethral resection of bladder tumor. In this surgery, we resect the bladder, and we resect the bladder tumor completely if possible, and we take a deep biopsy. So the important information in the histopathology specimen after surgery which we are looking for is, first, which type of tumor it is; second, what is the grade of tumor; third, what is the level of extension of this tumor into the layers of the bladder, whether it is invading the lamina propria or it is invading the deep muscles, because these questions will determine further treatment steps which are required for these sort of patients. And management is different for each patient depending upon the level of invasion and the grade of tumor.
So, doctor, when do you give intraoperative mitomycin C?
Okay, so mitomycin C is basically a chemotherapy which is given post-operatively, and it needs to be given preferably within 6 hours of transurethral resection of bladder tumor, and it is generally restricted to patients with low risk or low grade of disease. And for example, it is preferably, or it is advisable to give intraoperative or post-operative mitomycin in patients who have a single tumor less than 3 cm in size, and in which we feel the complete resection has been done, and we feel that mitomycin is safe to be given. For example, if the resection area is very large, or we feel that there are chances of deep resection into the bladder, then generally we avoid it. Otherwise, in every low risk feature tumor, this should be given.
Okay, now let's talk about the treatment options. The treatment for all cancer largely depends on how advanced the cancer is, and is usually differs from between early stage and more advanced stage. So, doctor, how does your treatment vary if the biopsy is a non-muscle invasive bladder cancer?
Yes, this is a very good question. I would say depending upon what is the grade and what is the stage. So basically, we follow certain set of guidelines. We commonly at our center follow European Association of Urology guidelines, and which have divided non-muscle invasive bladder cancer into different types of groups, which can be low, intermediate, or high risk groups. And as I have previously mentioned, low risk tumors are basically which are less than 3 centimeters single tumor, and papillary sort of tumor which are not invading the deeper layers of the bladder. And high risk tumors are multiple tumors more than 3 centimeter in size, high risk tumors or high grade tumors, and which are invading into the deeper layer of the bladder, which is lamina propria. And other in between are intermediate. For example, tumor less than 3 centimeter, but multiple tumors, superficial looping tumor but more than 3 centimeter, are somewhere in between intermediate risk of tumors. So for low grade tumor, TURBT with post-operative mitomycin is complete treatment, and this patient is then required to be followed up with regular cystoscopies. For patients with intermediate risk of intermediate risk non-muscle invasive bladder cancer, post surgery, it is recommended that we give him or her induction phase of BCG, followed by maintenance phase of BCG for about 1 year. So I have mentioned here BCG only, not other any chemotherapy, because there is good data that BCG is the most effective drug in this adjuvant setting in patients with non-muscle invasive bladder cancer to prevent recurrences and to prevent disease progression. And for patients with high-grade disease or high-risk disease, it is recommended that BCG is given as induction followed by maintenance up to 3 years.
So, is the treatment different for muscle invasive bladder cancer?
Yes, so treatment for muscle invasive bladder cancer is altogether. Now there is sufficient evidence that after adequate staging that we have proven that patient doesn't have any evidence of metastatic disease. Patients who have muscle invasive bladder cancer on initial biopsy, they should be offered chemotherapy given that they are eligible. And we generally refer our patients with muscle invasive chemotherapy to medical oncologists to assess their eligibility for chemotherapy, because there is now level 1 evidence that all of these patients with muscle invasive bladder cancer should be given chemotherapy first, followed by surgery. Now surgery for them, the surgery which should be done is radical cystectomy with type of urinary diversion which they would be eligible for. So muscle invasive bladder cancer requires much more aggressive and intensive treatment as compared to non-muscle invasive bladder cancers.
Okay, and when do you suggest newer therapies such as immunotherapy for your patients with bladder cancer?
First, I would say that the most effective treatment for even for muscle invasive or metastatic therapies, given that patient is eligible for that, is cisplatin based chemotherapy. And generally there are new trials coming up which are evaluating effectiveness of these newer therapies such as immunotherapy in the adjuvant and neoadjuvant setting. As of now, there is no level 1 evidence or even good quality level 2 or 3 evidence is not available right now whether they are effective in patients with muscle invasive bladder cancer in neoadjuvant or adjuvant setting. But this newer therapies such as nivolumab, as atezolizumab do have role in metastatic bladder cancer, where patient is not eligible for primary therapy, which is cisplatin based, or patient has disease progression on primary therapy, which is chemotherapy. So yes, they have limited role as of now in bladder cancer, but there are still studies going on assessing their role in neoadjuvant and adjuvant settings.
Yeah, thank you, Dr. Gopal, for your comprehensive explanation. And as we conclude this session, Dr. Gopal, your insights have been truly enlightening. We appreciate your time and the wealth of knowledge you have shared with us. So, thank you so much.
Thank you very much. Thank you very much for your kind invitation. Looking forward for further similar sort of things in future.
Yes, definitely, Doctor. And to our valued audience, we extend our gratitude for joining us today. Before we bid farewell, I would like you to explore our MedSynapse platform, which provides a unique opportunity to engage in enriching discussions, connect with esteemed medical professionals, and contribute to the progress of healthcare. Until we meet again, take care and keep advancing in your medical journey. I'm your host, Dr. Harshita, signing off. Goodbye.